Hi, you all. In case you haven't seen the emails, today's not going to be a normal session for Echo due to scheduling conflict with some of our panel experts. So we're just going to do a short Q&A for anything about processes, about how Project Echo works, and Delanor is going to be here from the School of Nursing, not the School of Nursing, sorry, Kentucky Nursing Association, to answer any questions as well. In case you thought this was going to be a normal session, my apologies. It was a last minute cancellation. We won't be on here for the full hour and a half, just a quick Q&A of anything we can answer about potential topics you want to talk about, things we want to focus on the scheduled sessions, and as well as anything we might have missed that there's a huge need for. We know we have a large group from Louisiana and Oklahoma representing a big chunk of those who registered. If any of you are on the call and you want to express a topic or information you need, I know dialysis is going to be part of the topic now. We saw that we had a lot of folks from that, and there's not that much information out there for it. So we start in just a minute. I'm just going to touch base with Delanor to ensure she is going to be on the call. There she is. Hi, Delanor. Hi, everyone. Thank you for joining us. It looks like we have 18 participants, so thank you all. So today's session is going to be a little bit different than normal. Like I said, we had to do a small cancellation. So we're just going to do a Q&A for anything we can answer about processes, and anything that Delanor can answer from the K&A perspective. I'm going to share my screen and show you all a little bit of what we're doing. But before that, since we only have 18 people on, we get to do something that we can't do when there's 130 of you on. So I'd love for each of you to introduce yourselves, your name and your affiliation and your role, because we don't normally get to do that. And this really builds a community of practice, and we get to know each other a little bit more. So I'll start. My name is Kim Buckner, and I work at the Division of Infectious Diseases, and I've been here for about 6 years. And I have the distinct honor and privilege to work with two amazing infectious disease experts, Dr. Julio Ramirez and Dr. Ruth Carrico, who you've seen. And it's just my honor and privilege to be able to facilitate these sessions and just be a part of it. And I just want to thank you all for all that you do on a day-to-day basis, and especially during this epidemic. And then I'll have Delanor introduce herself.
I'm the CEO for the Kentucky Nurses Association, and I've been here in this role for about 3 years. I'm a retired naval officer, and infection control is a passion of mine, so this is right up my alley. And I'm just really glad that Kentucky Nurses Association has an opportunity to participate and share the information, because the more information we have about this pandemic and what nurses' role can be, then the more things that we can accomplish. So I'm delighted to be involved with this project.
Thanks, Delanor. I'm going to throw it over to Amy Sands, if you'd love to introduce yourself, your name, your role, and your affiliation.
I think you're on mute, Amy. Let me see if we can get you off.
Amy, are you using a phone to dial in by any chance for audio? What? Give me a thumbs up. Are you last four digits 0718? Yes. Okay. Hold on. Let me merge you. Hold on one second. 0718. Okay, Amy, try now. I merged you, so we should be able to unmute you.
Okay, thank you. Director of Clinical Education with Galen College of Nursing, Louisville, Kentucky. Thank you.
Thank you for having us. Heather, Heather Elliott?
Hi, my name is Heather Elliott. I am the Director of Nursing and Wellness at Iris Memory Care in Edmond, Oklahoma.
Thank you for joining us. The screen name TRV.
That would be Teresa Villaran.
I'm chair of the K&A professional practice and advocate board director member.
And
Thank you so much.
And
where you worked?
I am a staff nurse with in-center hemodialysis.
Thank you so much for joining us. Kathy Miles.
I'm an area manager for Sisters of Nazareth. And sorry.
I said wonderful.
Oh, thank you. And I just joined to gain knowledge.
Awesome. Thank you so much for joining us. Rita Brown. Rita, would you mind introducing yourself with your name and your affiliation?
Maybe we could come back to Rita.
Absolutely. Melanie Fossen. Would you mind introducing yourself, your role, and your name and affiliation? We'll come back. Lori Wood.
Hello, everyone. I am Lori Wood with Santa Fe Pasteur Vaccines, and I am a key account manager in Kentucky. And I've been in the vaccine support role for about 20 years now.
Wow.
Awesome. Thank you so much for joining us. Rita Brown has let us know in chat it's not letting me speak. She is the director of nursing from Lake Cumberland Regional Hospital Special Care Unit, and she is listening to learn. Thank you so much. And Melanie Fossen said, I am the infection preventionist for SJH and SJJ. Melanie, would you do me a favor? Can you type in what those acronyms mean? Because I don't know what they do mean. So that way we can share with the group. Or let's go to the screen name GCORNN.
Hi, this is Gladys Corn. Can you hear me?
I can.
I am over infection control, both here at St. Joseph London and St. Joseph Berea. I have been certified in infection control. Next year will be my 6th time to recertify. And so I've been doing it for a long time, and then I've been a nurse for over 40 years. And I just find this challenging and interesting to do.
Awesome. Thank you so much for joining us. Mary Newton, would you please introduce yourself?
Yes, Mary Newton. I'm the infection preventionist at Flagey Memorial Hospital, part of the St. Joseph Health System, and that's in Bardstown. And I've been doing infection control for 9 years now.
Welcome. Thank you so much for joining us. Melanie, let me know that it's St. Joseph Hospital and St. Joseph Jessamine. Thank you so much. Monica Kensington, would you introduce yourself, your role, and your affiliation for us?
Yes, I am Monica Kennison, the nursing chair at Berea College, and I'm delighted to be here.
Thank you so much for joining us. Brittany? Brittany doesn't have any audio. I just realized that, so we'll move on. Lynn?
I'm Lynn Roser. I am assistant professor at the University of Louisville and an infection prevention consultant. I work with Ruth a lot, and I'm just on to see how things are going and gain more information.
Awesome.
Hey,
Thank you so
Lynn.
much. Bells up. Rosita?
Hello, everyone. My name is Rosita from New Jersey. I am a full-time psych nurse practitioner student at Frontier Nursing University, and I work part-time as a family nurse practitioner at a community health center.
Thank you so much. Brandy? Brandy, would you mind introducing yourself? Oh, my apologies. Brandy said I do not have a microphone. She's from Oklahoma State Department of Health Quality and Survey Analyst. Welcome. Kathy Allen said she's an RN and director of Epworth at Home Health and Hospice in Oklahoma, and just joining to gain some education. Last four digits on audio 1100. Would you mind introducing yourself? They might have stepped away. The last four digits 5177.
Can you unmute her?
They're both unmuted. Callers 1100 or 5177, if you'd like to introduce yourselves. You're both unmuted.
Hi, my name is Brittany Amick, and I'm the Infection Prevention Manager for
Thank you, Brittany. I merged your video and audio. So last four 1100. Anybody there? Okay, moving on. I'm going to share my screen just to give you a little overview of what Project Echo is.
We have Kathy Mershon on. She did not get an opportunity to introduce herself.
Thank you. Kathy, would you mind introducing yourself, your name, your role, and your affiliation, please?
Live here in Louisville, and I'm a member of the board of Kentucky Nurses Association, and I'm very proud of this production.
Thank you, Kathy.
Thank you.
Did anybody else? Did we miss anybody else? Anybody else would like to introduce themselves if they haven't had the opportunity to do so? Okay, so we're going to move on to the brief introduction of what Project Echo is. Pull up the screen for you. There we go. So what is Project Echo? Project Echo started at the University of New Mexico in Albuquerque because Dr. Sanjeev Arora, who is a hepatologist, realized there was a large number of patients in a very large geographic area that had hepatitis C and were dying, but with the right treatment, they could be saved. And so he realized that the best way to do this, there was only one of him, and his practice was in Albuquerque at the University of New Mexico. So he decided to train primary care providers out in the more rural or more desolate areas with the knowledge and the capabilities to treat hepatitis. And over time, they were able to prove with Project Echo that someone being treated by their primary care doctor for hepatitis C was receiving the same care and effects as if they came to the academic institution. So it was a wonderful model. So the whole theory behind it is people need access to specialty care and information, but there aren't enough specialists or experts to give that knowledge in person or to care for all these patients. So then Project Echo disperses information and knowledge and doesn't move the experts. So many people can join, even from very rural areas, to get the information of care and as well as information. And so essentially the bottom line is that patients will end up getting the right care at the right place at the right time, and this will improve their outcomes and reduces costs. And so with COVID-19, this is even more important because by giving you all the information, you all are able to protect your patients and yourselves all over the country. So this is essentially how Project Echo works. So if you all were like, what in the world is this thing? So it creates a learning loop. So you can see there. So we have the Echo Hub team, which consists of Dr. Ruth Carrico, Dr. Don Balcom, and Montre Smith, and the lovely Delanor, and myself. And so essentially, we'll disperse knowledge and information to you all. You all are spokes. And then the goal is that you all will continue to deliver that information to your practices and your health systems. So, what is the role of Project Echo in COVID-19? How are we going to do this? Well, we're going to try to share as much information and updates as we have. Put attention and awareness on the key topics for nurses, some self-management skills related to mental health and well-being. I know Delanor has talked about the nursing line that's dedicated to this topic. Delanor, do you want to talk a little bit about that? Hold on, you're muted. There you go.
Okay. We have on our website information about COVID, and we also have a 877 toll-free number for nurses to get peer-to-peer support. We have resources on our website, and if you go to our website, in fact, I could share my screen and show you where it is, but it's on the website and it's right under our home, which is the top on the left-hand side. So if you're interested in seeing how to get to that, just let me know. But we realize that nurses on the front line are going to have stressors, the everyday stressors of going back to work, home, and then stressors of whether they have PPE, the right PPE. And so they may just need someone, a skilled person to talk with about that exposure. And so we have a program, it's called Kentucky Nurses Helping Nurses Program. And we have on a weekly basis on Friday from 12:30 hours, as Kim has taught me, they're not webinars, they're actually sessions because they're interactive. We are having sessions on Fridays that anyone can attend. And you're all invited. We've had some incredible present Friday sessions. I wanted to mention to everyone that Dr. Carrico has a few minutes and she has been able to join us. So if you have some questions about infection control questions, if you'll put them in the chat box, so when Kim finishes her presentation, if Dr. Carrico has an opportunity to answer those chat questions, that would be great. Is that okay, Kim?
Oh, absolutely. I'm actually sitting, I don't know if she knows that, across the hall from Ruth right now. Let's get back. It'll be almost done, I promise, and then we can get to the fun stuff with infection.
This is fun stuff. This is really important. I have to tell you, I didn't know much about Project Echo until Ruth introduced it to me. And then, Kim, you've been very instrumental in me learning how it can work and how it can help us to improve our practice and all over the world, actually. So I really, really appreciate your time to do this.
Thank you. I love being a part of this. So, like Delanor just said, this is important because we're going to try to create a community of practice. We're all in this together, and we want to share this and get to know you all. And it's a safe space. This is a space to ask questions, comments. You can help each other out. We're not just here to talk and tell you everything. We want to hear back from you because that's the way we're all going to learn the best and be able to give you the best information that we can. So at any point in any of the Echo sessions, if you have a question or comment, just stop us and we'll be able to help you. Ruth is actually walking into the room with me so we can sit together. Ta-da!
With that mask on.
Oh, 6 feet, 6 feet. But
put those masks on.
Put the mask on. But we are so grateful for you all here. And so when we ask you to put your camera on, it's just so we get to know you and see your beautiful smiling faces and just, again, create that community of practice. And so, again, like I said, we want to spread information and practices peer-to-peer. And we encourage you to do the same thing with your peers at your sites. as well as anybody you want to know. So anybody in healthcare can join these sessions. If you all need the registration link again, please let me know. But we are hopeful to be able to share this with as many people as we can.
I think too, if I can add to that, we want to be able to use this method to address some contemporary problems and issues. So, for example, we've been talking quite a bit about the importance of immunization as we approach
One
the
second.
fall.
Ruth, one
Are we
second.
gonna-
I have my headphones in, so
Oh, okay. Oh, sorry.
hold on one second. Let me get Ruth on the microphone. This is not gonna work. No.
I don't know if we want to share and get COVID. So,
sorry, we're going to restart what Ruth just said.
Sorry. She had to take her earbuds out, and I said I didn't want to share her earbuds, so I didn't get COVID ear or whatever is gonna whatever new illness is gonna occur. But we want to use this modality to address the contemporary issues that we have in responding to COVID-19. So just as an example, we have been, really working to think about what are we going to do with respect to immunization. Now, we know that an actual vaccine for COVID-19, we don't really know where that is. We're gathering more information and hearing a lot, but we know with the president's emphasis on warp speed, and we know that our industry partners in the vaccine world are, they're nothing short of incredible, and they are certainly working on this to try to bring not only a new vaccine, but from our perspective, we need to be thinking about what is happening now. So many of you have probably read in the journals about what is happening regarding a routine immunization. I think I read something the other day that I think it was just a CDC MMWR response that said about 60% of parents now are getting their children vaccinated with just the routine childhood vaccines. So if that's any type of a marker about what we might expect regarding influenza vaccination this fall, it's letting us know that that's going to be a huge challenge. So, and if your a Kroger is like my Kroger, I've got crime scene tape around the pharmacy. So you can't even get to the area where you would routinely be getting vaccines. So, our use of pharmacies for vaccination may not be what it has been in the past. So we're going to have to think about what are we going to be doing differently. And we're going to have a communication and an education method, not only with partners such as K&A, but how do we get the information across, and then how do we share best practices as they are emerging? Let's build on what we know has worked, but how do we bring something new and then engage the population? Because again, remember, the most trusted profession is still nursing. So if we're going to impact then the public's acceptance of vaccination during this time where everybody is just stressed to the max, and it's all coming out in all many different ways. But we want to use ECHO as a way to get groups together to have these interactive discussions, just like the benefits of ECHO that Kim has been talking about. How are we going to use that to address not only COVID-19, but the full area of how we improve the health of our community. This also will give us a direct way to work with industry, where we can say, we're going to take then the knowledge that we have about what you are doing, and we're going to operationalize that through education. And then we're able to respond faster and I think be more effective. That way we're bringing our knowledge to the knowledge with our industry partners. So I think this is really, it's kind of a different way of doing business during a very different time. So COVID-19 is providing a lot of challenges, but at the same time, a lot of opportunities. So Kim, let me give it back to you as you go through. And do you want me, Delano, I know you had mentioned a question about returning to work. How about, you want me to do that now?
Yeah,
Kim,
do that now. No, go ahead.
Okay. So maybe, and I'm not going to say I've got all the answers, but I think maybe just the discussion in this group, we might find out some of these answers. So if there was a chat, was there something in the chat?
We had,
or if
there was There was a question, Ruth, and it was when we first got on, and it was about schools and students returning to school. And so the question was from Amy Sands, and it said, any information regarding the re-entry of students into the clinical settings, healthcare settings for clinical hours would be helpful. What type of guidelines and timelines are healthcare settings thinking about right now? What consideration factors are affecting your decision-making in accepting students for clinical hours once again in the healthcare setting? Excellent question. And Ruth, you're on.
Amy, you might, if you want to unmute yourself, you may have something to add to that question, and then we can kind of share some info. I see your.
Hold on, Amy, hold on 1 second.
Okay.
There you go, you're unmuted now.
Perfect.
Okay, thank you. Good morning. Yes, I know there is a KBN meeting this Friday with regard to the amount of clinical hours that are going to be accepted, virtual or simulated hours versus inpatient hours. They have made some changes to the regulations at this time due to the inability of students being in a healthcare setting to complete clinical hours. But I would just like to get from the healthcare partners that are on right now, just any thoughts or any considerations that measures, steps they're taking to get students back into their doors, and anything that the schools of nursing can do on their behalf to help with, in that progress, getting students returned to the healthcare settings for inpatient clinical hours.
Sure. So I'll hold my 2 cents worth until we get the information back. And I think if somebody wants to unmute, just hold down the space bar?
If you're on the computer, just hold down your space bar to talk, and then if you let it go, it'll mute yourself, and it's *6 if you're dialing in.
So while folks figure out if this is something that you want to weigh in on, or if you just want to listen, I guess let me kind of give my 2 cents worth of this. Looking at it from and my perspective is going to come from how do we protect the healthcare infrastructure? So knowing that the healthcare infrastructure needs to be educated, but this needs to happen in a safe way. That's kind of the context. So my first thing is, I guess, if we look at, what are the rules of engagement here? The first rule is that a student needs to be competent to perform whatever job, and that means in the academic setting. If we are going to send them into a clinical rotation, our job as educators are to make sure that that student has the competencies to practice safely. So if we do our part, if we have taught them to perform safely, then they should be able to perform safely. That without a clinical experience, we are not enabling our students to do what they are supposed to do. That they are here to actually learn how to care for patients. So we need to teach them the skill set and have some sort of competency assessment and validation in place. And then if a student is not able to demonstrate competence, then we shouldn't be sending them into the clinical environment. If they are deemed competent, then they should be in the clinical environment. And that means that they need to be able to perform. So if the healthcare facility is saying, we can't have them here because we don't have enough PPE, then we need to figure out, how do we gather enough PPE? And is it then the school's responsibility to send students with adequate PPE to perform? So somehow, that's part of that negotiation. If it's because there are concerns about liability, then I would say in the affiliation agreements that you have, that should be part of the affiliation agreement, that the students are sent so that with the knowledge and the ability to apply that knowledge or competence, so we don't send a student that is not competent to perform into the healthcare environment. So that's the affiliation agreement. Either way, I think the students must come back to school and must be able to learn to do what they are going to be required to do as part of their job responsibility. I know everybody is looking at, should we be culturing everybody? Should we be doing all of this. And for my mind, I think that we need to remember this is a virus that is here. We are not immune to it, at least a majority of us, and we still don't understand immunity enough to be able to say anything about it. So this is a virus that's going to be with us. We have two choices. We either stay at home and we hide from it until we have a vaccine or until something happens in the future, or we say this is part of our ecosystem now and we figure out how to live with it and we figure out how to do that safely. I would just use this also as an opportunity to plug in the whole idea of vaccination, and that even when we use our best vaccines, and I'm going to use high dose flu because we have data about the not only efficacy in the clinical trials but real world effectiveness. Even even having the best flu vaccine available, we still can't get everybody to be vaccinated. So if we say, oh my gosh, everything will be solved once we have a vaccine, we still can't get people to accept vaccination, and we know no vaccine is 100% effective. So please don't wait and think that's our beacon or our end of mission. We need to be back into the clinical environment in a competent way, in a safe way, and we recognize illness is going to happen. It's going to happen in our students, it's going to happen in our faculty, and we need to be prepared and equipped to address that and know when do people need to stay home, when can they safely return to work, and under what circumstances they return to work. And people need to know how to use PPE. And it's my hope at the end of the day that finally people will keep their hands clean. And finally, people won't go to work when sick. And finally, people will cough in their sleeve or, do all the things that our mother's been telling us to do for forever. Maybe we'll actually do that. So that's a long answer, Amy. The short answer is we need to get back into the clinical environment ASAP, and we need to make sure they're competent to care for patients. Patients are expecting us, the nurses, to care for them. So we got to do it.
Monica chimed in and said, Ruth, I fully agree that we need to learn how to live, not hide from COVID-19. I fully agree with the solid arguments that Ruth is presenting. And Brandy said, amen.
Oh, good. See, I was raised a Southern Baptist, so here I am like I'm giving a sermon, and I feel like I'm all sweaty now, like
that could be COVID. That could be COVID, really. There's Amy, do you have anything to add? Anybody else have any comments or questions about that?
This is Lynn. Can you hear me?
Yes, ma'am.
Okay. I'm with University of Louisville School of Nursing, and I'm also an infection preventionist. And Ruth had asked us to write a piece, an opinion piece, that is really going to outline the task forces that we developed to think through many aspects, not just clinical, but many aspects of returning to school. And we're busy writing on that now, because hopefully it will help provide schools different things to think about, and maybe even offer some of the ways we've kind of worked through some of these problems. A lot of the information that will guide us in clinical is still not out there yet from the clinical facilities, because ultimately they will be the ones to dictate, what their requirements are for students to return. But this piece should be finished and in Ruth's hands probably by Monday.
Yay! Woohoo! All right, I'll be here. I'll be working on Memorial Day, so I'll be looking for it.
Oh, I forgot it was Memorial Day.
Don't say Tuesday now.
No, we said Monday. We said Monday, and we're sticking to it.
All right. Very good.
May I request that the Kentucky Nurses Association have an opportunity to publish that when it is ready for publication?
Yeah, Delano, I think this will be excellent. That we can provide this as soon as it is accepted, and we've got a rapid turnaround. So, Lynn, I'm glad you brought this up, because anyone that wants to submit an opinion piece or a perspective to the Journal of Respiratory Infections, everything is COVID focused right now. And please remember, I know it seems like a lifetime ago, but we've been dealing with COVID-19 for, 5 months. That's it. And look at what has been accomplished in 5 months. It's absolutely incredible, but we're only making this progress because of our willingness to share. So my boss said, Ruth, I read this book, Love in the Time of Cholera. That's a story, it's kind of a romance between two people. It's a Spanish novel, and it's since his name is Ramirez, he obviously, speaks Spanish. So I'm making a generalization. I guess that's okay to do in this
Julio
time
Ramirez.
of craziness.
He's from Argentina, for the record.
So, he said, what we need to be doing is thinking about life in the time of COVID. And so that really has become our theme, that we're looking at life in the time of COVID, and our perspectives are, nursing in the time of COVID. What is happening during this time, what is impacting our practice. And if we wait for the evidence, right now, all the evidence is coming from China, and I'm not really sure in some places how appropriate or applicable that is. So what is happening in the United States? And so our journal is focused on rapid turnaround. So when these pieces are sent in, they are reviewed at lightning speed, and they are immediately posted electronically, and PubMed has given us the approval to wait until the end of the year to combine everything into a single volume. But the idea of getting that up very quickly, so as soon as it's available electronically, I will make sure, Delner, that you have it, and we can add it then to the website. And so, anyone, we want your feedback. Please remember, nursing is driving the care that is being provided. So we need to have a voice about what is happening. So, don't hold back.
And I also want to let you all know that the journal is my baby. I'm emotionally attached to that, helping it have given birth to it almost. But it is peer reviewed, and it is 100% open access to publish and to read, because both Ruth and Dr. Ramirez believe that knowledge should not have a cost tied to it, and that knowledge should be shared freely. So just want to let you all know that. Does anybody else have any comments or questions?
Yes, can you hear me?
Yes, Mayor, go ahead.
Okay, well, I have one question that's about, in my acute care hospital, we have a separate 12-bed skilled nursing facility unit. We have dedicated staff to that unit, and visitation, we have universe control. We have a sign-in. Anyone that goes into, any staff member that has to go onto that unit for any reason has to check their temperature, record their signs, any signs and symptoms, etc. And well, so with the CDC's recommendations for our director is really concerned as far as making sure that we're following best practices for our use of PPE. So this is a short-term unit where people only stay for like 3 weeks or less. Generally, it's for rehabilitation, or strengthening, after an illness. So yesterday, she sent me a query. We had already been over this, and we've already been visited by the OIG, and they were satisfied. But when new residents come in, then her question is, do we need to have them in full contact precautions with use of gowns, etc.? Now, we have universal masking already. We use gloves, hand hygiene and all that is excellent. And I said, I thought that standard precautions would be satisfactory for that 14-day period. And of course, if a patient has a draining wound, or if they're had secretions that are not controlled, then that's different, and we can do more if we need to. But I didn't think it would be necessary to use up our gowns with providing full contact precautions with every new patient that comes in. That's non-symptomatic and everything too.
So
what do you all think?
So if I understand you correctly, these are not patients who have been tested and have been positive for COVID-19, right?
Correct.
So these are patients that are coming to you from a healthcare facility into and transferred to your facility, right?
Correct.
Yeah, there is nothing in any recommendation that says that they need to be in COVID-19 isolation. If they have been tested and were positive, they would need to be tested before they are released and before they come to you.
But
Right.
recognize that any individual may be asymptomatically may be infected and asymptomatic. So you're covering that by your universal masking practice. So you're doing
Right.
universal source control. So I think that the issue with these patients would be you would use your standard precautions with them, but you would be aware that just like anyone else, they could conceivably be infected and infectious. And so you're going to need to monitor them for 14 days just to make sure
Right.
that they were not infected unknowingly before they came in, and then follow
Right.
your standard practices for them, and just like you do for everybody else. But I think
Yes, and we're doing that.
yeah, and
With
mind that many facilities now
what
are
else,
many facilities now are testing on admission. So your patient may have already been tested while in a healthcare facility, just to try to determine what was going
right.
on with them as they came in. So if you're able to gather that information, that's great. But I think I would treat them as you do any other COVID negative patient, recognizing that certainly there is a risk, but use of PPE, I think, would probably not be appropriate at that time. And I'm assuming that if somebody you admit is exhibiting symptoms, then you would handle them as a potentially positive case, and then being able to isolate them based upon their presentation of symptoms.
Correct. Yes.
I think I'd agree with. I'm in your camp on this, Mary. I don't know if anyone else has any comments, but that would be the way that I would suggest approaching that.
Okay. Thank you so much.
We've got a similar question to from Heather Elliott in the chat. With the lifting of restrictions in my state, I'm concerned about lifting visitation restrictions for my community, even when the state allows them to be lifted. My fear is that we will have another spike in cases, and my residents, who are all in the vulnerable population, will be exposed, causing an outbreak in my community. Do you have any recommendations regarding how long to wait after all restrictions are lifted for maximum safety of my residents? Heather, would you let us know what state you're in, please, in the chat?
Well, I think, with this response, I'd always, number
Oklahoma.
one, Oklahoma. I'd talk with public health to say, this is my concern, just in case they have any additional insight. But, again, the reality of this is that the disease is present. We are going to see disease in the community. Our emphasis is not so much on can we prevent that disease. We can't. It's already there. You're going to have individuals in your staff that are going to come in. You are going to have visitors that will come in. This is a reality of this pandemic. Our focus is on how do we mitigate the impact. So how do you have a process that you may be able to recognize this early? I think that it's perfectly reasonable to be able to still say, as visitors come in, we need to, it is your responsibility to make sure you don't come and you're sick. That's when, the greatest likelihood of transmission will occur. Certainly people can transmit when they are asymptomatic, but we think their viral load is probably lower, and that it may be more difficult for them to transmit. I think that's the idea of saying, the whole focus is on universal source control. And we've already seen the impact of doing that. Everybody that comes in wears a mask, wears respiratory protection. You do that all the time that you're there, and that we enable and facilitate hand hygiene practices, and that our personnel are attentive to environmental infection control. So, that's the best way to approach all of this, I think. And that, are we going to be uneasy and insecure? Absolutely. We're in the middle of a pandemic. All of us are going to be uneasy and insecure, and things are going to happen. But disease is going to continue to occur. It is part of, we can't control the fact that it is present. What we can control is how quickly we recognize and what we do to protect those that are vulnerable, but realize, one option is not to put everybody in a bubble. That
we I think have lost sight of how horrible it is for our community when you are isolated from other people. Most of us are social. My husband told me the other day, man, I was made for a pandemic. I love, I love being all alone and, not being around everybody. This is great. I'm the opposite. I'm a very social person. So I'm experiencing physical pain because I can't hug and, that's what I want to do. So, we are seeing an increase in domestic violence and intimate partner violence. We are seeing, depression and anxiety and PTSD related to this, my inability to interact as a human. So, everything is a balance in our life, but we know we have got to open up our communities. But we've got to recognize and control disease so it doesn't overtake us. We don't want to be in this situation like New York. We knew somebody was going to, quote, go first. And we've seen the communities that have gone first and they've figured out, how to deal with this. So we are gaining from their insight. But it doesn't mean that we're going to be able to get away from this organism. We have to be just as clever and relentless and ferocious and fearless as this virus is. And hiding away from it is not going to help us. We're going to have to get in front of it.
So it's really more a matter of having a plan that mitigates risk versus, any type of a plan that, because there is no elimination of the risk, which we realize. Yeah. And yes, we absolutely, in the Alzheimer's population that we care for at our community, it's the isolation is horrible and causes more decline. And yes, we absolutely are seeing that as well. So, okay, that really helps. Thank you.
You said that much better than I did, Heather, and in a lot less words. Any other questions or comments?
Ruth, would you address where people can go to get information to shore up their knowledge on COVID-19 and things that they should be doing in their environments?
Sure. I think, I've got a political cartoon that I shared with a group from Australia yesterday that was in the Courier Journal a few weeks ago. And it's this guy talking to his wife. And he's like, wow, honey, all of my Facebook friends that last month were constitutional experts are now infectious diseases experts. And I think that is so right. I'm finding all kinds of people that overnight a miracle happened and they learned everything there is to learn about infection control and are now leading the charge. So I think at this time, it is really important to go to credible sources. So I always say, go back to CDC and look at the learning management system that CDC uses. Is called TRAIN. It's not particularly user friendly. You get in there and sometimes I get lost and all of that, but it does have a lot of really good information that is evidence-based. I think where it stops is that, remember, CDC is responsible for gathering the evidence and they say, here's the evidence. What they stop and don't do is tell you how to apply it. And so you will get a lot of, here is the evidence. And so our evidence-based recommendations are to do this, whatever this is. Our challenge is always, well, how exactly am I going to do that? How do I implement? So you can go to CDC, get the basis for what we know about COVID-19. And then I think it's a matter of getting together with groups to, just like this, to kind of talk it through and figure out how am I going to apply this and what makes sense. Because COVID-19, again, it has changed. It's turned upside down many of the what we thought were the truths of infectious diseases. It's challenging our typical way of approaching, things that we thought we had a pretty good handle on. We've learned are probably not. We really don't know how to deal with this, and some assumptions that we have made, I think, are problematic. This is why one of the things that I continue to press with nurses is our problem in understanding immunity. That I do not want nurses to think that some of these rapid immunity tests should be used to make any decision. My fear is that a nurse is going to have one of the tests and they're going to say, oh, I'm immune, therefore I don't need to wear a respirator, or I don't need to worry about, a mask or hand hygiene, or I'm not worried if I have a fever. I know it can't be COVID-19 because I already had an immunity test. That may place them at risk, their families at risk, and their patients at risk. So we need to, look at this information and then get together and say, how do I interpret this? How do I understand? So the long way around is, let's start with CDC and then find groups like this, like go back to KNA to say, how do we convene a group of individuals to talk through this particular aspect so we can understand what's the data, what are those data, and how do we apply it so we know what to do with it. But don't listen to the a lot of the crap and the local, or the experts that now, last week, worked in the car lot, and this week they're going to tell us about infection control. We've got to kind of look at history, and let's use the resources that we know kind of live this and understand it.
And we'll put some links in box for you all. I know we already did some there. And then you can access that whenever you want to. And I know Jessica Petrie, who's not on this call, but she's our librarian here on the school medicine, and she is more than happy to put together information after each session for you all. And we'll put the links up to the articles there as well. We have another question in the chat from Monica. It says, what are your thoughts about elementary and high school students returning to school for fall, assuming Kentucky permits it?
So, yeah, somebody was asking me, well, do you think elementary students are going to do any better than high school students? And I don't know. I mean, this is going to be a challenge that, again, we have a disease that is transmitted by sick people coming to public places or workplaces. High school students are invincible, right? I felt invincible at that age. So they feel like none of this applies to them. Elementary school kids are in daycare, they are the masters of germ sharing. So even if they try really hard, they just can't help themselves. So we know that when we begin to return, we're going to have outbreaks. We're going to have, transmission. I think the only way to address this is by having measured reopenings. And determining what is it that we have to do, what can't we do remotely, and how do we augment education? How do we keep kids from falling further and further behind? I'm worried about the health disparities because I see it's poverty that creates our health problems. It is not genetics; it is poverty. The fact that we do not have people that have access to healthcare, and they have heart disease because they can't see a dentist, and therefore their plaque is loaded with bacteria, and that causes heart disease. That we have to recognize the importance of poverty and addressing poverty. If our kids in poverty areas don't have internet access and don't have somebody at home that is helping them with homework, and we can't allow them to fall further and further behind. So from a societal perspective, what's the biggest issue? Is it that we are concerned about transmission of COVID in this setting? Yes, we know that's going to happen. Is the bigger issue that we will have children that are unable to be educated, so they will never break out of the prison of poverty? At some point, how do we make that our priority? So, I'm for bringing kids back to school where they can learn together. Yes, I feel badly for the teachers. I feel badly for the nurses that are taking care of sick people. How do we then teach our teachers how to protect themselves? And do we recognize that kids are going to share and they are going to transmit illness, and that we have to identify illness and be able to treat them? Fortunately, significant disease in children is still rare. It's not it's not one of those never events. It does happen, but our community needs to be able to care for them and to realize that we have a choice between two bags. Which one's worse? Is it worse to keep our children so they are unable to be successful and we continue to have this widening gap of disparity in education and health, I think that as nurturers, as the nurses, we can't allow that. So bring them back, and we've got to figure out how to deal with it.
I want to let you all know, speaking on that, I have a beautiful little 10-year-old girl who is almost completely her life since she was 3 years old been around this amazing person. And she is like a mini infection preventionist. And she made a video for her classmates about masks and hand hygiene and everything. And so my thought on this is we need to make a lot of mini infection preventionists, and then they can teach their classmates and their teachers the way that we know best. And I think that might be a good thing. You have a little like, didn't they have like guards or like hall monitors? They could be like infection prevention monitors.
Well, but I think too at the other end, I have 2 grandchildren. I have a granddaughter that's 4, and both of her parents, my son and daughter-in-law, have been working from home. And so when I go to visit my granddaughter, we have just now reached a point where mom and dad feel comfortable enough with me to get close to her. In the past, we have connected. She would hold a broom out, and she held one end and I held the other. And she would say, Lala, as she calls me, Lala, I feel you holding my hand. And I thought the damage that we are doing without the physical touch and what the value of interaction. And so what is happening to our children, that they are afraid of physical touch, that how are we going to get back to this period of time? Because how important is it that we connect with each other? And so, I look at these experiences and I think about, my physical involvement and my touch needs to be more than holding the other end of a broom. It needs to be the type of touch and nurturing that occurs among humans and is particularly part of nursing practice, the art of touch that we have and the importance of touch. And so I just bring that up because I think that is an important part of this discussion on how we bring and allow society to re-enter. And do we do everything around the need to swab you and draw your blood to determine if you can re-enter society? Or do we figure out a way that is not perfect, but is going to be good enough, that allows us to reconnect? And then, of course, we are ready when we have vaccine and all of our safe injection practices are up to a speed, and that we are all then dedicated to using then primary prevention to help us move forward. So if you want to come around me and we want to touch with a broom, we can do that, but that's not my ideal.
Oh, we have another. Monica said, I fully agree that the risk of delayed education and social isolation as being far greater than the risk of catching COVID-19 for our students. Thanks for the great arguments. Does anybody else have any questions, comments, concerns? Cool. So we're going to adjust the schedule a little bit. So session 2 was a little delayed because we had some hiccups in scheduling, but we will still do that topic. It'll just be a little delayed, and we might add a session or 2, depending on what you all had suggested. I know we had talked about dialysis, especially some stuff with the nursing education students as well. So thank you so much for the evaluations on that. That is extremely helpful for us.
And I think we want to try to figure out and have a way that we can provide things that are value to participants. We want to provide CE. So to do that, we need to meet the requirements and make sure that we're honest in our approaches, get everything to Deleanor, who through KNA is helping us do all that. We need to figure out, how do we provide CME? How do we provide then, can we also provide pharmacology credits then to our advanced practice nurses that need that as well? So we're trying to navigate all of this and get the most important, the contemporary content in ways that are of value, I think we were a little bit, I was not sure how well accepted this would be, and I trusted Kim to do this as a jump off point, but I think ECHO is clearly the way to go with this, to allow us this type of engagement. And we're going to be going full steam, and hopefully really be able to have that we've got a real infection control training institute approach to be able to bring content and deliver it in a way that you can then turn around and use it for other purposes, so that we kind of keep this as a living approach. So we're figuring it out in the midst of it's infection control in the time of COVID. So everything in the time of COVID.
We had a comment that said, "This is by far the best information and session I've attended anywhere so far. Great job and great comments." And thank you so much. That means a lot to us.
We'll keep on keeping on.
And this is Lynn. I wanted to tell you, I was so impressed with the turnaround last week's session and evaluations and everything. Was that K&A? Who was that did that? Because they did an excellent job.
That was me. Thank you so much.
I just want to tell you, it was very user friendly, and as you know, I'm trying to get something going to hook up to the main shell of infection prevention, and it gave me a really good idea of how things worked.
Awesome.
Good.
Thank you so much.
So we've got in the sessions that we can make available so people can use them in there. And so what's our process for doing that?
So every session, including this one, is recorded. And so the last session, I'm going to edit it because that was a new setup with the TV. And so I just have to edit some of the video content so it looks more user friendly, and the slides are more of a focus than everyone's little heads. But besides that, going forward, we'll have it ready in a couple days post the session, and that'll be in Box. And then I know Delanor's going to archive them on K&A. So you'll be able to see that, as well as any resources and materials will always be in Box, that one link, and I'll send that out again next session. So you all have it. So the agendas will be there, the PowerPoint slides. The one thing we didn't get to, because we had just jumped into Ruth, is case presentations. So the heart of this model is you. So if you all can submit, you get those emails before every session, to submit a case. So that could be a patient case, that can be your healthcare setting case, that could be just an overall question that you have concerns, or a success story, something that you did well, or something that happened in time of adversity that you were like, well, we didn't have this, so we did this. The thing that comes to mind is I saw images from a friend where the nurses had created elongated IV tubes and had the IV post outside the room. So then that way they weren't going in and out as much as they needed to. So they kind of created something out of the adversity they were facing. So please submit a case. Everything's de-identified. And then you can ask the case. You'll submit it in REDCap through that link. You'll present it yourself. If you don't feel comfortable, we can do that. And then our panel of experts will be able to weigh in on that for you. So nothing is too simple. Nothing is too complex. But I do ask that you guys do that. You can pick whichever day works best for you.
Nurses are innovative.
Very, very much so.
All right. Excellent.
Well, thank you guys so much for joining us for this Q&A session. We will send out the information for the upcoming sessions. We're going to revise some stuff a little bit. So just hang on with us. And I promise that this journey will be exciting and rewarding. And we just had Amy said, Louisville's better having Dr. Carrico lead us all in infection prevention and control. I so appreciate your generosity in sharing your expertise and common sense approach. Thank you. She is amazing. If you don't know her, you should. She is one of the best humans around. So
good. I don't know how to do anything else. I tell people I don't know how to cook. My house is a wreck. And I never cut the grass. I don't know how to air, my plants, my husband calls them death row. So I don't know how to do anything else. So I'm a one-trick pony. This is it. So
Support truth, though. Thank you guys. Have a
right.
wonderful,
See you
safe
later.
week.
Thanks.
If you have any additional questions, just email them to me, okay? Thank you.
Bye.